Good evening. Good to see you.
Who is this?
This is Sunanda ma'am from Palliative India. Yeah.
One second. Slideshow. Slideshow.
Yes, ma'am.
What to do? Slideshow?
From beginning, the first bit.
Acha, from beginning. Okay. So, welcome to my session, and today we are going to deal with home-based care. Do they have any assignment or something like that today? Presentation, something? Nothing, no?
Nothing, ma'am. Nothing, ma'am.
Okay. This is the fourth session, huh?
Yes, ma'am. This is
Fourth session. So, communication, they have come.
yeah.
Okay. So, home-based care. Today we are going to deal with home-based care. I just would like to know from you all, what is the difference between hospital care and home-based care? One or two response in the chat box, it will be good. Just would like to know, what do you think about a hospital care and a home-based care? Why we are talking about home-based care? Because you all have joined as a volunteer, right? To learn about this. So, somebody what more comfortable for the patient at home. Neelajan. Okay. Any other thoughts? I hope you all are listening to me. Only Neela, okay, personalized monitoring, that is again Deshmukh only has sent, very right. Okay, so hospital has good infra, whereas at home we have limited. Okay. Home patient benefit, homely atmosphere. Dr. Umesh, good. Yeah, everybody have their own opinions. Okay. So, so let us have a look. See, home is a place of memories. We are very familiar with our home and we feel safe also, safe and secure at home. And home is such a place where we relax. Nobody is going to question you. You want to lie down, you can lie down. You want to walk, you can walk. And the best place for freedom, right? Freedom of choice and autonomy is there. And in the hospital, it is not there. Of course, I agree. In acute phases, we need to be in the hospital. But when it comes to a long-term disease and a long-term problems, best place is home itself. Nobody likes to be in the hospital for a long time. Everyone has only one thought: as soon as possible, let us get discharged from the hospital. Okay. So home care, because every patient has got a fundamental right to receive good quality of care at the place where he lives, especially when it comes to a life-threatening illness or a long-term disease where the patients won't be able to go every now and then to the hospital. Think of a very elderly people. It's very difficult. They have the fundamental right to get their good quality of life where they live. And the availability, accessibility is very important. And home care is to make the treatment available at home whenever it is needed. And why? Because home care is very different from hospital care. Best place for caring the chronically ill patient, as I said, because they will be supported by their family. Of course, if you can ask me, how about during this era or Okay, nowadays it's very difficult. I can understand. Most of the time, elderly people are left alone without their children working somewhere else. They are left alone. They are not supported by their family members. But still, people love to be in their own home. Visiting a patient and family in their own homely atmosphere, they feel very good. When a patient is there and when we go and visit them, they feel very happy. And to provide quality patient care in the home and a community setting. So we need to build up a community where we have all these resources, at least go and see the patients. And where the patient will feel there are people who are caring for me. And as I said, who needs a home care? All chronically and incurable patients. Incurable diseases are the chronic illness, age, dementia, a lot of things are there. Physical disability, like bedbound patients, paraplegias, like that patient who cannot reach out to the hospital. Lack of conveyance, like you see in a tribal area or in the villages where they don't have a proper conveyance, where they cannot reach out to the hospital. And especially when they are bedbound and all, there has to be some care has to be given in their community itself. Lack of caregiver and too sick to travel. Financial constraints. See, a bedbound patient has to be brought to the hospital. At least 4 people we need to shift the patient. Somebody has to be there with the patient. And they have to pay for the ambulance. It becomes difficult. Relatives' report are not proper. So in many of the hospitals, it happens that if the patient is not able to come to the hospital, relatives will come and report. But maybe that report is not correct. Aging groups with health problems. As I said, and long distance, terminally ill patients. We cannot shift. Don't think that terminally ill patient doesn't need any care. They too need the care till their death and after the death to their family. So this is very important because when we go to a patient's house, we will see where he is living, how the people who is taking care of the patient, what care they are giving. The actual carer will come to know. Many times this has happened with us also. When we go for home care only, we'll find out that the person who was visiting us in the hospital is not at all a carer. He's just a neighbor or a far relative who has just come to collect the medications, or so their report also will be wrong. And the need, of course, again, difficulty in coming to the hospital, as we said, mainly physical disability, living in a remote place, no transport facilities, financial constraints, and of course, lack of caregivers. Only one person will be able to take care of the patient, and how that person will shift this patient to the hospital. Home care, the need, hospital stays upsets the normal rhythm of life. Many times it happens, husband and wife are in the hospital. If one of them is not well, no one else to take care of the children at home. Their education is disrupted. A lot of things happens. The rhythm of the life goes ups and down. So, and at times, if they had to take also, the person who is working, there will be a loss of pay. They have to pay for their expenditure of the accommodation, food, travel, hospital stay, they have to pay. Sometimes even the medications they have to buy. So the disruption of the domestic demands and children's education. In a hospital stay, this is what happens to a normal life. And that's why we say home care is needed. Acute phase, it is okay because they may be there hardly for maybe 3 days, 4 days, or 1 week. After that, they are discharged. But when it comes to long term, it's very difficult. And again, patient being has the advantages seen in his place. Because as we said in the first slide, freedom is there, privacy is there, and the power of taking decision. When they are in the hospital, they are more anxious. But when they are at home, at least their anxiety is little reduced. And for us, we get a complete picture of the family and we can give a better care. And of course, teach the correct caregiver how to take care of this patient at home. Suppose like wound dressing, how to give feed through the Ryle's tube, I mean the nasogastric tube, how to feed, how to give a oral care, how to give a bath. These things we can teach the family member or the caregiver so that they can give the care to the patient. So home care is the ideal method of to identify the rehabilitation needs of the patient and the family also. That is also, in a home care, we can see what we can do for the patient, how to rehab the patient and the family. And of course, home care ensures adequate follow-up also. So treatment from the hospital alone does not relieve the symptoms. Patient and the family have a lot of anxiety about the things, what is happening. Okay, so symptoms may be relieved, but once they go back, it doesn't mean their symptoms are totally relieved, especially when the patient is in a long-term disease. They will have a lot of other things also to think about. Many factors will interfere with the care. So home care is the best thing to do. So home care is the best way to enhance the relationship between the patient and the family members, patient, family, and the neighbors, and of course with other social organization. Like, we can teach the family member about how to make a bed better, how to take care of the patient's wound. So the relationship between the patient and the family improves. With the patient, family, and the neighbors also. Many places, the neighbors help the patient and the family in small things they help. In the day-to-day, what is happening, they can come and help. And with that, what happens in the community also will help that family. And we can make a good relationship or build up a good relationship with other social organization, asking them to take care of these patients who are in their own community. So, like if we go with the vehicle, people all will notice that this vehicle is coming again and again. They will try to find out what is happening. And if there is a social organization over there, they will find out and they will come for the help also. In any way. Okay. Some or the other way they may help. And home care identifies that the caregiver is as important as the patient. That's very, very important. Patient is suffering physically, psychosocially, psychologically, socially, spiritually, financially, and all. The same thing happens with the family also. The family also is undergoing a lot of psychosocial, financial problems, even physical problems also. And everything, whatever the patient, for the patient, who is doing, the caregiver is doing. And the caregiver is also an important person, just like the patient. And we need to build up or empower the patient and the patient's caregiver when it comes in terms of the death of the patient. And home care is cheaper, better option, visible impact in the society. It has a very visible impact on the society. And human resources in the form of trained volunteers and committed professionals. A lot of professionals have committed that they'll be working somewhere else, but a set of little bit of time to take care of the patient in their own community. And if we have trained volunteers, they can take up this and they can run that organization to take care of their patients who are in need in their own community. And this will influence even the government also. So local self-government institute can make positive contributions. Like if PHC centers there in Panchayat and all, these volunteers can go and help the PHC center doctors and nurses can ask them to take care of some patients who are in the hospital or at home. So many things can happen. Only if we keep a step forward, we can bring this into action. So there are many types of home care. One is doctors-led home care, where doctor, nurse, maybe there's some volunteers are there or trainees are there. Nurse-led home care is the main thing. Nurses are the leader. Mainly, most of this one is nurses-led home care, where the nurses will be the trainee doctors and other nurses will be the training. Volunteers can also be there. Many of the home care volunteers are there to help the nurses when they go alone for the home care. And of course, the volunteer-led home care. In your own society or in your own community, whenever you are free, you can just go and visit these patients alone. Sit with them, talk to them, find out what are their problems so that you can inform the palliative care. So what are the components of home-based care? Physical care is there, emotional care, social care, and spiritual care. We'll come one by one. So the basic services, what is being provided is assessment of the symptoms. Okay, we need to assess the symptoms through effective communication. Sir will come to know what problems they are having so that we can give a good psychosocial support. General hygiene of the patient. Pressure sore prevention and management we can give. Wound care we can do. Bowel and bladder care we can do. The nasogastric tube feeding and care. Stomach care and lymphedema care, and ensuring medicine compliance. Of course, telemedicine or talking over to the patient family through a video call or WhatsApp call or a video call. This also will help to an extent. If suppose a patient is in a far village and the patient is taken care by any doctor, they can have a WhatsApp call or video call or even telemedicine. Through that, we'll come to know if the patient is having any problems or not. And even volunteers can help in this. They can go find out, they can call the doctor and say, these are the problems the patient is having. So many things advanced things have come, especially during the COVID time. Now, physical care, you can see here. Patient is being taken care. We are just assessing the patient head to foot. Total assessment of the patient. What is happening? And if the patient is having some symptoms, we can treat for that. Provision of any physical aids and of course follow. That is the physical. Like the patient is having pain, we need to give medications to relieve the pain. Patient is having breathing difficulty, nausea or vomiting. This all need to be assessed. So assessment can be done by doctor, nurses, even volunteers can assess. For example, see, if my mother is not well, don't think that I am a lay person. Okay. When my mother is not well, when I take her to the hospital, I tell the doctor, right? I explain to the doctor, like, my mother is vomiting. When she vomits, all the food particles are coming out. Okay, she's having breathlessness. While walking, she's having breathlessness. At rest, she's doing that. See, these symptoms, the person who is accompanying can also explain. And also, as a volunteer, when you are visiting a patient, you can just ask the patient what are their problems. And you can help the nurse or the doctor by informing them these are the problems. So emotional support. 1 second. The emotional support. Just have a look. This is the palliative care person talking to the patient. Look at the patient's hand. Patient is trying to tell something. Maybe he's asking to that person, why am I lying down like this? What's the point of me living like this? There is no meaning in my life. That person may have fear, anxiety. Even some patients are there saying, if I'm able to get it from there, I'll commit suicide. I don't want to leave. Feeling loneliness. Feeling of being burdened to the family member. But we need to sit near the patient, listen to them, and give the support. Emotional support is very, very important. A volunteer can do it very well. Just listen to the patient. See, in our home, in our own home, when we have some problem, we do support each other, right? If suppose I'm having some problem in my workplace, I come and talk to my husband about that. I share it. And same thing is with him also, or with our children. So that is how we can support emotionally each other. And that is very important. The social and rehabilitative care. Now, what we can do here? You see, if I am the head of the family and I'm suffering from something, some disease, and I'm not able to go for a job, there will be no money and my job also will go. And if there is no money, no food. Many houses are there, many people we have come across, loss of job and no food at home. People have lost their home also. Many people have lost their land for the treatment. Everything they have sold and they're given for the treatment. And finally, nothing is there for them. Children's education is disrupted. Some people cannot get their children married off. I just came to know just 2 days before that one young man, almost now he's 45, somewhere about 40 to 45, is taking care of his both elderly parents. And after that, his father is bedridden. He's not married also. He's happy in the sense, what I came to know, he said, it's him, I'm taking care of my family, my parents, and it's my responsibility to take care of them. And he's not married. Because he got that fear that if I get married, the person who is coming, she may not look after. Maybe something is there. And no status in the society and the stigma. See, we need to rehabilitate these people, do something for them so that they can earn their living. We can teach them. Otherwise, we can approach any organization, tell them to put a small shop for them. Otherwise, if they are good in making some, like making umbrella or making these bags, this is shoppers and all, something like that, so that at least they will start earning. We can help in their children's education. We can approach the school, find out what is the problem, tell them what they are facing, at least to give a good education for them. Many things can happen only if there is someone to support them, and that also from the community. And spiritual care, of course, the question always arises, why God has punished me? Why this happened to me? I did not do anything wrong. I led my life in a very good way. I've done a lot of charity work, but still now I am suffering. And it can be the other way also, because I have done something wrong. That is why these things happens. But for this all, as a volunteer, I need to sit and listen to the patient, to their story. We need to give time. Maybe once in a week, whenever you are free, you can just go and listen to. Like we keep here talking to the elderly people, right? Just sit with them. They'll be talking about their past life, what has happened in their life. Maybe they were there during the war time. Then they will just explain to you, tell you what is that, all stories. And they're allowed to tell the story. But to whom they will tell if nobody is listening? They need someone. So when we are ensuring compliance, proper instruction has to be given to the family members and the patient. All the medications has to be labeled, that also in bold letters or capital letters so that they can see it properly. Just writing the medication, no. Medication has to be written, for what it is given, it has to be written, and the timing. And we have to check the medications the patient is taking in every visit. And of course, consider the financial status also. And of course, in a patient's room, what we need to have. See, one calendar so that they can see what's the month, the date, the day, the year. In some of the house you go, nothing will be there. Patient doesn't know whether it is day or night, whether this is January or March, they don't know. They don't know even the day. They don't know the time also. So just in opposite of the patient, there should be a calendar, there should be a clock, all in working condition, okay? And suppose the patient is bedridden, but the patient loves to read the newspapers or books, please ask them to provide it. Ask a family member to keep a torch at the bedside of the patient. Anytime in the night, if the patient wants to look around, a small torch is very important. A bottle of water, a glass, so that whenever they feel like to have some water, they can. If the patient is bedridden, but the patient can move on the bed, is not fully dependent on someone. Okay. A small basin, why, if I want to wash my mouth, I need to spit it also water, right? So keep something like that. Calling bell, it's very important. See, sometimes my voice won't come out. I need to call someone inside the house, maybe my voice is not coming out. So a bell, if I keep for the patient, ring the bell. Otherwise, just keep a steel plate or a steel glass or a spoon. They will bang on it. So the person inside the house will come to know that patient is calling. And a wheelchair or a chair just near to the patient's bed where the patient can move out of the bed to the wheelchair or a chair. Some patients they are bed bound, but they can move from their bed to the wheelchair. Okay, even the paraplegia patients, if I say. So provide these things at the bedside of the patient. Now, I'll come to the main thing. You all must have come across when the patient is lying down for a long time in the same position or sitting in the same position, they will develop skin problems, that is ulcers, what we say, on their back. So how to prevent it? We'll just have a look. First and foremost, whoever is bedridden or a patient is there, the person who is giving a bath to the patient, okay, should not wear any jewelries or rings, so that when they rub or apply soap and all, their own ring or jewelry will give injury to the patient. Okay. Proper bed making is very important. Many of the patient's family doesn't know how to make a bed with the patient because they cannot move the patient. So from the nurses, you all can learn how to make a bed. It will be very helpful even at your house also, at your home also. That we call it as an occupied bed. When the patient is in the bed, how to make a bed. Avoid friction. How we will avoid friction? Pulling the sheet. So once if you know how to make the bed, you will avoid that. Then avoid application of soap directly on the body and of course avoid talcum powder. Why? When you take the soap and apply directly, it makes your skin more dry. So what they have to do is apply the soap on the palm, little, and then to apply on the body. Encourage fluid intake only if there is no restriction. Okay. Ask them to take more water. And of course, keep always the skin dry. Otherwise, I will take not very dry, but of course, it should be dry and clean to prevent infection. For that, we need a good bath. Bath should be given to the patient. Very important thing is, soon after a meal, please tell them not to give a bath. See, these are the small things which you can learn and you can teach the patients and their families. Immediately after a meal, no one should take a bath. So set a time daily to give a bath. Maybe a bath before the meal, well and good. After the meal means only after at least 3 to 4 hours. Okay. Now, these are the common sites where we will get a pressure ulcer. I am coming to that. I will show you what is a pressure ulcer also. See, many times, see, this is the elbow in between the knees when we are lying on the side. And of course, when we are lying straight, see, this is a supine position. Head, shoulder, lower backache, and the heels. I will come now. You can see. See, when you are lying on a sideline position, on a side, these are the places where you will develop pressure ulcer. Second one, you see, if you lie on a prone position, these are the places where you will develop. Next, in a sitting position, head, shoulder, sacrum, buttocks, and heel. So this we have to prevent. So I'll come to that in the coming slides. With that, special attention should be given when giving a bath to the patient. So this you can teach the family members. The first place is the eyes. See this fold. You see this fold? This is a place where this dust will accumulate. So you need to wash with nice water nicely and wipe it. Second place is this nose. Inside the nose and this place, this folder. So when we wash it, we have to wash it thoroughly like this. Most of the people, what they think is the patient is on the bed, patient is not going anywhere. So from where dust will come? Once we sweep the house, mop the house, that itself will give dust. Okay. And another thing, from outside, lot of dust will come inside the house. So automatically the patient also will be dirty. Patient will have here and there, dirt will be there, accumulation of dust will be there. So this needs to be cleaned. So the proper cleaning of the patient. See, if they are giving a good bath in the bathroom, well and good. But if the patient is on the bed, these are the site where they have to give attention. Now, back of the ear. This is another place. We will apply nice soap, shampoo and all, then we'll pour water. But what happens at the back of this here, the soap will get accumulated, it will become dry, then we will start scratching and it will make an ulcer. Same thing inside. See, these are the places where not only I'm talking about the patient, even for us also, these are the places where we forget to give attention. Now, when it comes to the hand and the feet, in between the digits, fingers, and in between our toes, we have to give attention. Why? This is the place where we will have fungal infection, all these nails and all. So give a proper attention to these places. So immerse the hand in some lukewarm water so that our nails will become soft and it is easy to cut. Most of the bed patients, the nails will be so brittle, so big, nobody will cut it. Teach the family member just to immerse in some water in a basin, and after that when they cut, it will be easily cut. And we can prevent even the cracking of the heels. The heels become very hard, there will be crack, it becomes very hard. And if they dip or immerse the feet in water for about 10 to 15 minutes daily like this, and then clean it with small brush on a daily basis, the crack will slowly heal. So after washing and all, they can just apply some Vaseline or little oil or something like that, so that the crack will heal. So in between the fingers and in between the toes, that is very, very important. After taking bath, if they are taking a bath in the bathroom, just wash the feet once more in between the feet, because all the dirt will accumulate in between these toes. Umbilicus. Ask them to apply little oil here and then to clean it. Then comes in between the buttocks. This is a place where dirt will get accumulated. The patient is bedridden, patient will pass motion, urine and all, and this will flow here and it will become dry. Under the arms, on the elbow, the folder for the folding place. Again, special attention. And of course, when the patients are very obese, see the folds here. So what we have to do is just pull the chin like this, wash it, then bend the neck, then wash this area. Special attention we have to give, because this is a place where the dirt is getting accumulated. Dust, I can say. Groins. See, groins. Under the breast, and of course, you see the abdomen is sagging forward. So under the abdomen, see, that is very important. Of course, for the ladies, under the breast, and of course, the popliteal, back of our knees. Okay, so these are the areas where we have to give attention, and you have to empower the family member. Tell them these are the areas where you have to take care while giving bath, or even if while giving sponge bath on the bed, they are giving the bath. These are the areas that you have to keep an eye. And why so? Whenever you give a bath to a patient, you can see the skin of the patient. If the skin turns red, it means the patient is going to develop an ulcer. And so we can prevent it. So that is why daily inspection of the patient's body is very important. Daily bath is very important. If they are not able to give daily bathroom bath, at least thrice in a week, they can give daily bath in the bathroom, bathroom bath, and rest of the days, at least they can give a sponge bath on the bed. Care of hair is very important. Of course, if they are not able to take care of a long hair, take the permission from the patient and they can cut it. This you have to explain to the family member, because if a long hair is there, they won't give daily they won't give proper hair care, and that will produce pediculosis. And in turn, there will be ulcers will be there, bad smell will come. So again, what I used to tell is, nurses can teach the family member how to give a head bath on the bed itself. So here, whenever I take a session for the volunteers, I do teach them these things so that they will learn and they can in turn teach the patient's family. So this is very important. Even you can help. Nothing more, you can, at least you can help while giving bath. That is very important. Oral care is important. Next, for the bedridden patients, again, in the home-based care, what we do is we give even oral care. We teach the family member how to give a oral care. Mouth care is when daily we are brushing, right? So same thing has to happen for the patient also. So we teach them how to give a mouth care. So like if a patient is able to move, just give all the things for the patient: brush, paste, water, a basin, everything, patient will do it. But if suppose the patient needs someone's help, we need to stand up. So this we have to teach the patient's family. How to give a, this one, what to say, how to brush. Maybe I have to stand with the water and all next to the patient will do it. But in some cases, patients are able to brush and all, but we need to hold a basin under so the patient can spit. So whatever help the patient needs, we need to do it. Just to finish the work. So these things we teach the family member, tell them that if to make the patient independent, just give the things, let the patient do it. Only you just assist the patient. See, whatever I have told you, all these things are done in a home-based care. Because we empower the family member, the carer at home, to take care of the patient. And that way, what happens is we are reducing the isolation also of the patient and the family. See, oral care can be given to the unconscious patient also. In a patient who is conscious, just we need to be next to the patient with the water. And while that we can talk to the patient, we can listen to the patient. And next, what we teach in the home care is about the feeding. Okay, the patient already will have a tube in the inside the nose, which goes to the stomach. So how to give feeding? So always we teach them that whenever a patient is given a feed, the patient should be in this position, not on a lying down position. This position is very important. If the patient lies down and we give the feed through the nose, sometimes the patient will aspirate. Because aspirate in the sense, the patient may bring it out and then again it will go inside. Sometimes it will go to the lung. Patient may die, otherwise patient will have pneumonia. We call it as aspiration pneumonia. So in order to avoid that, we tell the family member, teach the family member, always this patient should be in this position when giving a feed. And after giving a feed, put the patient on a side lying position, on a side, so that if the patient vomits also, it will come out. And of course, we teach what we can give. Say in the market, you can get like, what is that? Ensure, protein powder, everything you will get. But for poor patients, whatever they are preparing at home, that they can give. Like they can give vegetable soup. All the vegetables, if they are boiled, take little vegetable, mash it nicely. Even with the hands also we can do it. Add some water, nicely mash it. Strain it, that they can give. Fruit juice they can make at home. Dal. Any poor patient, they will have dal at home. Dal is very good. They can give milk. Then even they can give the rice water. After cooking, that water is there. Drain that water, put little salt, they can give. If they are making chicken, just take the soup of the chicken, they can give to the patient. So these all are having protein. So whatever is made at home, prepared at home itself, they can give. These are the things very important. And after the feed also, let the patient be there for at least for half an hour. The patient should be in the same position, and then the patient can be put on a side lying position. So again, in the home-based care, especially when the patient, before the discharge from the hospital, the nurses educate the family member how to give a feed. And you as a volunteer, if you go for a home care with the nurses, you will learn a lot of things through which you can educate the family caregivers. Now, bowel care is very important. Most of the bedridden patients or a long-term patients, the problem with them is that there is no bowel movement. Constipation, we say. They will say very hard stool. Otherwise, they will say, I'm not able to pass motion because it is very hard. Why? Because they are always in the bed. There is no privacy. There is no exercise. They will reduce intake of the food and the water. And of course, some medications also will cause constipation. So the important thing is encourage the patients for bowel movement daily and give time. And encourage the family member to give high fiber diet adequate fluid, and of course, if you are giving medications, to give that medications properly. And this all happens before the discharge of the patient from the hospital. Because the patient will be there for some time in the hospital. So these things has to be taught to the patient. But in palliative care, when we talk about palliative care, it is the family member, the importance of the bowel movement, importance of giving the medications, and if it is not given, what will happen? That is very important. Because the patient will be constipated, there will be, this one what say, abdomen will, they will have abdominal discomfort, they may start vomiting, they won't have their food. So daily bowel movement is very important. See, if the patient is put on a commode also, see that one stool is kept here so that this position is maintained. If the patient is in this position, they won't pass motion properly. So this position is not proper. We need to keep a stool so that the patients, and if nothing is there, they can keep even a bedside commode they can give. So I'll show some more photos. Before that, this is the bladder care. You see the patient's abdomen, so big. Bladder was so full, urine was not coming out. 1500 ml urine came out after that. Okay, so here what happens is, a patient should be encouraged to pass urine at a scheduled time. If the patient is bedridden, patient can pass, keep all nearby the patient, urinal or a bedpan, so that when the patient wants to pass, let the patient pass. But suppose the patient is passing urine without knowledge, urine is just coming out. In that case, we have to pass a catheter. So it is the family member how to take the care of the catheter. Daily, if they're taking bath, automatically they have to clean the catheter also. The bag they have to maintain. The color of the urine we teach them, so that if there is any problem, they can immediately call the palliative care nurse. And cleaning also, like whenever the patient has passed motion, it has to be cleaned thoroughly because the tubings will be there. It has to be cleaned. So cleaning just with soap and water will be okay. See, if we don't put a tubing, the patient will pass urine, will be lying down on the urine. And what happens after lying down on the urine? The patient will develop an ulcer. So we need to prevent that. So again, bladder care is being taught. And in bladder care, what all we can do is, usually the catheter is changed within 3 weeks to 1 month. Okay. Encourage the patient to take more of fluid so that the urine will flush out nicely. We can prevent infection. And if there is constipation, again, they will have infection. That's very important. And you know our Euro bag, I will show it. See, this is a Euro bag. This is the bag. Okay, this is the bag. This should always be kept below the waist level. See, this is the waist, below the waist level. Why? The urine has to drain from here to here. It should have never they should hold the this one bag here. Because the urine will, this will cause infection. We are preventing infection. So this we we have to teach the family member, and we have to tell one more thing. Never to detach. See, this is attached. This tubing is attached to the catheter. Never to detach it. So whenever the bag is half full, they can bring one mug over here or anything, this one can or something. They can open it and the urine will drain out. So again, these things we have to teach the family. So that is what about the bowel and bladder care, what we know, the home-based care, whatever. Sometimes some patients have already been discharged from the hospital, and the patient's family will come to us saying that they want to register in the palliative care. So when we do the first home care, we see the surroundings, what we have to teach this patient, and slowly we start teaching the family member and the patient how to take care. Okay. And one of the important thing in that is exercise. If there is a bedridden patient, the patient needs a physiotherapist support. But of course, if a physiotherapist is not there, many times the nurses can also teach the family member how to give simple exercise to prevent the contractures. And that is very important. And of course, how to prevent the pressure ulcer. Simple, keep always the skin moist. Whenever the patient is lying, every 2 hours, we have to shift the patient's position. That is very important. If the patient is sitting, ask the patient to relieve the pressure. And the skin should be kept clean. Daily bath is very important. Whenever there is the patient is passing motion, urine and all, clean properly. Bed should be clean. But what the bed sheets we are putting, it should be clean, wrinkle-free. Because this sheets also will cause pressure ulcer. Okay. Daily inspection of the bony prominences. I mean the back and all the points we have to see if there is any redness. If you suppose you see redness, we have to start shifting the patient's position. We can use water bed, air mattress and all we can use for a complete bedridden patient. Then that nutrition is very important. A balanced diet we have to give the patient if there is no other problem. Okay, so after cleaning and all, just apply some moisturizing cream, Vaseline, liquid paraffin, and keep the patient active in the bed also. You can do simple exercise so the patient on the bed itself, patient can do his exercise independently. And how we do it is, you can see practical demonstration of whatever you are doing, the practical demonstration you have to show to the family member so that they will learn and just see how they are doing it. Even wound care is being done by the family member. We teach them how to do the dressing and all. Okay. So the patient's family, they do the dressing. And we make a follow-up in the home care. See, these are the proper position, how to make the patient sit. This is one thing. You see this one. Whenever the patient is lying down, you see, this is the best position. Keep some clothes folded in between the two bodies where it is touching. To prevent foot drops, see, we can give a board over here. Sideline position, you see lateral position, what we say. This is also good. But you see where the pillows have been kept. That is important. So, this is as I told you, pressure ulcer. You see the skin has turned red. So, it means it is going to break down very soon. So, what we have to do is start shifting relieve the pressure. Now, the second one, you see, it is broken. Skin is gone. Just a little bit cleaning and then put a small dressing on that. Again, relieve the pressure and nutrition. You see, this can happen. It has gone a little more deep. In some patients, it will be very difficult to heal. If you don't take care, this will go into this stage. You see this one. Very bad. And this will be very difficult to heal. You see this side? And again, you see, bones and all we can see. It will become so deep. So right from the beginning, if we take care, again, the thing is, nurses teach the family member, show them and tell them that we have to prevent pressure ulcer. It means we have to keep changing the patient's position. Every 2 hours, they can change the position. Nice massage they have to give. Daily bath as far as possible. Inspection of the skin. You see, very bad. This is all negligence. Okay, this is suspected injury. It will go. So, patient can do means put a overhead bar. See this overhead bar, patient can just hold that overhead bar and relieve the pressure. Patient can turn to one side. And if the patient's bed is put on the, see, if these bars are there, okay, if nothing is there, just ask them to put a bar from here to here, a wooden piece or iron piece, so that the patient can hold it and turn to one side. Nothing is there, the patient they will find difficult to turn. Put their bed on the window side. I always tell, put the patient bed on the window side so that the patient can hold these rails and turn. Keep the windows open. The patient can take fresh air from outside. The patient can look out, feel that he is alive. Put the patient's bed on the window side. The patient will hold that rails and can shift the position. Backrest available in the market. Otherwise, even some people they make also, especially the people who are living in the villages. If they see, they can make it out with some wood or something. You can put the patient near to the wall also and put 2-3 pillows. Position is done. This is air mattress and water bed. Air mattress again. For that we need electricity. Okay, current is out. Water bed, then we have to fill with the water. But even if the patient is in air mattress and water bed also, we have to shift the position. Not every 2 hours, but at least 4 hours slowly we have to change. See, on the this can be used on the top of this one, Indian toilet. Patient can be made to sit because maybe patient is walking, but the patient cannot squat and sit. So this can be done. One more thing is there, you see, old chair, make a hole in the center and you see that bucket is kept. Another device. Patient is not able to go to the toilet. This can be done for the patient. So many things we can do, whatever resources we are having at home, that has to be modified and used. So, thank you. It's my final. So, any questions?
If you have any questions, please ask.
Hi, good evening. There are some questions in the chat. Read that.
Chat.
Madam, can you hear me?
Yeah, sure. I can hear you.
Right. Yeah, this is Sneha this side. I would like to ask something with maybe one patient. He's very aware about the situations and
Can you be a little more louder, Sneha?
yes. Yeah. Can you hear me now?
Yeah.
Okay. So maybe one patient who is in palliative care, he is bedridden and during his maybe final days, he's in so much pain and he wants morphine. Okay, he knows about morphine and he wants morphine, but the bystanders or caregivers are they have some sort of taboo about the morphine and the usage of morphine, and if they are not allowing the usage of morphine for the patient, and what we can do as volunteers to support the patient.
See, first and foremost is in the palliative care, usually the doctors and nurses explain to them why we are giving morphine and what is morphine and all, etc., etc. Okay. No? So we need to first, as a volunteer, you can do one thing is what you can do is just explain to them. See, you are not suffering, but the patient is suffering from pain. And the patient needs relief of pain. How they are, how can you just stand and see the patient in pain? And why they are scared of the morphine, and you have to, if they are scared of the morphine, then you can just ask your doctor or the palliative person what it is exactly. You can learn about the morphine and you can explain to them, because morphine is not a, what to say, like people think that it's an addictive. If the patient start taking, they become addict to that. No, morphine is given just to relieve the pain. And if the pain is relieved, patient will sleep nicely, patient can take what to say, food properly, and the patient is not going to disturb anyone. And if they are not going to give, the patient will be sitting and crying, and the family also will be disturbed. So here communication is very important.
Okay, understood. I had some personal experience, and there has been too much difficulties to even convince the doctors even to use give morphine for the patient. So there is no legal side or something like that. If the patient wants it and the bystander is not giving to the patient, and they are too much suffering, we cannot, at any cost, we cannot give the morphine without the bystanders or caregivers approval, right? We
Yeah.
should get their approval to give it. There is
Mm.
no other way. As a basic right of the patient, we can give the morphine to the patient. Is there any something like that?
My best this one answer for this will be, better that doctors should take up a palliative course, palliative training, so that they will come
Actually,
to
I
know.
suggested them.
Yeah, so that fear of giving that morphine, that will go from their head. They will also start seeing the patient, and I could say it is not directly giving morphine. Okay, we said WHO ladder. There is a ladder to give these medications. Okay, first step we will give is some other medication. Second step, some other medication, and with all these steps, the patient's pain is not controlled. Then only we go for the third step where we give morphine. Okay, so my opinion is that, and my suggestion is that doctors who are scared in that, just explain to them, please doctor, why don't you take a course, why don't you go for a training program of palliative care. Palliative care is having training program online also. So some things they will learn, and that fear will go. Because we all are using morphine. 17 years this only. So some things what you can help is just tell them to attend some courses like this, so that they will become capable, that fear will go, they can help their patient, reduce their suffering, give a dignified death for them.
Understood. So dignified death is actually one of the main thing we are concerned about when we are closing to the old age. But actually when we are closing to that age, a lot of the things are depending upon our caregivers, maybe our children or spouse, or whoever is taking care of us. Their decisions affects a lot of things, right? Maybe if we want to do something,
The thing is, who are maybe it is, I don't think, and if it is illiterate also, literate persons also, I think more of patient. These family members, of course, when they hear this morphine and all, they don't know exactly what it is. Like for what we are giving, they are very scared, thinking that if you give morphine, the patient will become addict to that, something will happen. And these things are there in their mind. So the best thing is the education. That's what we say. We have to sit and communicate with the patient's family about these things, so that they will understand and they will try to reduce the suffering of the patient. So communication is very important. Without communicating, just giving, they won't give it. Why we are giving the medications, what is the purpose of that, and how the patient will feel. These things are very important, especially when the patient is in a cancer patients. In the advanced stages, towards their end of life, the pain will increase. And you ask any of the family member, they will feel very sad saying that we can't see him in pain. So our aim is what? To reduce the pain. So here communication is very important, and that's what, if we get the patients and the family right from the beginning, in palliative care, we can teach them a lot of things. That is very important.
Understood. Thank you, ma'am.
Welcome, dear. So any other
Thank you.
questions? See, they have already put in the website this one, what's the training for the doctors and nurses. So anyone would like, they can do this. A lot of other courses are there. You can go to the palliative care websites, just put it, find out. Lot of other courses also are there. Any other questions? Anyone?
I think that's it. Ms. Sunanda, do you wish to say something?
No, I want to just remind, I think there are some questions in the chat box. I think
I
Dr.
can't
Asha, and,
see- I can't see any questions in the chat box.
let me just check.
Yeah.
Is that from Asha Deshmukh? Can you elaborate on how to involve
Yes,
the
yes, yes, yes.
What is that?
Can you elaborate on how to involve the local government in helping to form a community group of service?
You have to approach your panchayat first.
So,
yeah.
following that, so do they all doctors, nurses, and volunteers work together, or they work as and when each kind of care is needed?
So in our setup here in Kerala, there is a policy already. There is a government policy is that all the primary health centers, which is in the panchayats and district hospitals and all, we have palliative care. Okay, most of the this one government doctors and nurses are being taught about palliative care, so that wherever they are working, they can give the patient the palliative care, and they can, of course, connect the palliative care and with the patients. Okay. And from the PHC center itself, it's a it is a teamwork. Palliative care people are also there, and the doctors. So they go with them for their home care and all. And suppose only the nurse is going for the home care and they find some problems, they will call up the doctor and tell so-and-so problem, so that over the phone, they will give them the instructions. And if the patient has to be shifted, the patient can be shifted. So right from the primary, secondary, tertiary level, we do have support, not only from the government support, of course, we have NGOs also. So many of the NGOs are working with the local self-government like PHC centers of the, and these volunteers are the other people who are helping more in these cases. So for this, actually, the common people need to raise their voice, ask the government to bring a policy of palliative care everywhere. And the national program has a palliative care, like NHM and all that do have palliative care. National program is having palliative care all over the states. Okay, where the doctors and nurses has to be taught about the palliative care. It's a training programs are there. But how far it is being done in every state, that I cannot tell you. Okay, many states are still falling like towards the southern states. Palliative care, this one training programs and palliative care is good. Okay, when you go towards northeast and all, palliative care is little bit just coming up only, but it has to still grow up. So these are the things. So voice of the common people is very important. They have to raise the voice for these things.
Thank you, ma'am, for addressing that.
I hope I addressed your question.
Yeah, she said thank you. Yeah. Is there any another question? Or do you want to share some experience? Anyone wish to?
Sangeet, I just want to share something here. That if any participant are from Maharashtra, so I would request them to join us, because we already have a Maharashtra volunteer group. Because what happened with continuous these kind of VTPs, after the volunteers training was over, they contacted us that now we are trained, so how can we help? So we are trying to have more and more people in the group. So all those who are from Maharashtra in this group, so after the training, they can get in touch, and we'll make a big group, and we'll see how we can plan and make use of all of you. Thanks.
Okay, please do kindly touch.
Can I say something?
Yeah, sure, Dr. Asha.
Yeah. So in the beginning of the chat, so my daughter who's in class 11 has also attended this. So she's written saying that a person will feel safer at home even if they're critically sick than if they're moderately sick and in the hospital. Is that true? Is what she's asked. So I don't know if she's still in the meeting, but ma'am, I just wanted to know what kind of patients do you actually keep at home in the home care, and when do you decide you may want some kind of an acute care in the hospital? Like, what is the factor
When the
that
patient,
decides?
see, so for example, I will tell, suddenly one patient had a stroke. Okay. How far
Yeah.
you're, how far you're, how long you're going to take care of that patient in the hospital? At one point,
Yes.
the patient has to be shifted to the home, right? So
Correct.
from there is a long-term care. And suppose we see about their age and rest of the things where the patients need a long-term care. The patient cannot be kept in a hospital. You have to shift them, right? So there the patient needs a home care. In the home care setting only, you can help the patient. Same with the spinal cord injuries thing. Okay, any of spinal like accidents and all, where the patient may be in a semi-conscious, how long we are going to keep in the hospital? Even in a government hospital, we are not going to keep them for more than 1 month, right? So once the patient is shifted to that place, it's a long-term management of that patient, right? Okay, so there we have to equip or make the family member competent enough to take care of the patient, keeping in view right from the hospital. The first day or 1 week, we have to start thinking this patient is not going to be a patient who will just get up and walk after some time or something like that. So this patient needs it. So we have to teach the patient everything, right, to feeding, for the family member, catheter care, about the bowel care, these things, everything we have to make them competent, then send back the patient to home. Suppose if the patient has developed an ulcer from the hospital, mostly in the ulcer, because I know past 6 months, one palliative care patient has been looked after. So the patient had some dyspnea problem. They have taken to the hospital. 2 days, the patient developed ulcer. Okay, so we need to teach them how to prevent a pressure ulcer. And suppose pressure ulcer has come, how to do the wound care also. So that we teach in the home settings. Okay, now we'll come to the third group, talk about the cancer patients. Okay, cancer patients can walk and all, but there is a time where they won't be able to come back to the hospital when the disease advances, right? So see a lung patients with a dyspnea. Very difficult to shift the patient sometimes, and especially in this era, it's very difficult. Nobody's there at home. Only 2 people will be there. So these things, if we teach them properly to take care of the patient at home, they can take care. Now everything is there, CPAP, BiPAP, and all the PAPs are there. Okay, they can, if they want to give, they can give oxygen also. But the care of the patient, so communication, you need to teach them even how to communicate with the family member and the patient, how to communicate. Because they have a lot of psychosocial problems. But for that, we have to have time. We have to spend time with them, tell them what the patient is undergoing. We can, of course, understand the family also is undergoing a lot of problems. So how can they overcome? How can they come? And even now, most in our setup itself, people are giving their numbers. Okay, they will have the doctors or nurses number will be there. Any problem, they will have a video call. They will show this is what is happening. So over the phone also they can help. Okay, so as she said, when we tell critical care, let me tell you, when the patient is in the end stage, suddenly the patient is having a like head and neck cancer, patient is having a blowout, carotid blowout, patient won't reach the hospital, right? So we need to teach the patient's family how to take care of that patient at home. And the patient is end of life care. Okay, so if we teach them what is end of life care, they will take care of the patient and the patient will have a peaceful death at home. Without oxygen, without hydration also. But we have to teach them why the hydration is not being done, why oxygen is not given. That communication gap is there in between the patient and we healthcare providers.
Thank you, ma'am.
Welcome. So any other questions?
Is there anything anyone wish to ask? I think that's it. Thank
That's
you,
it.
ma'am.
So thank you all so much for your patient listening, and have a not nice day, I will tell, nice night, I will tell, good night.
Thank you.
Okay, thank you, dear.
Thank you.
Bye.
Thank you,
Thank
ma'am.
you.
Thank
Thank
you.
you.
Thank you,
Thank you
everybody.
everyone for joining. Thank you. Let's see you in the next session. Bye. Thank you.